Good morning, everyone. Thank you all for joining us today at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Center for Substance Use Training and Telementoring, CSTAT at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, please click on the speech bubble icon at the bottom of your window. To all the Beeville, Texas providers, please make sure you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your name and phone number to beevilletx@utisca.edu. Also, please note that we are recording these sessions for later distribution through the Beeville YouTube channel. Any info you put in the chat will not be shared in the recording. We encourage everyone to join by video, especially for the discussion portion in the latter half of the session. That said, regardless of how you're here, we're just happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the reactions menu on the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. And you can use the chat to share your perspective as well. There's a lot of us in this space, so please keep your comments brief to allow others a chance to speak up. And finally, please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, or pictures, or any information that could easily identify an individual. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It helps us get feedback on how to refine and shape these sessions to address your priorities, and it allows you to access free continuing education. We are approved for CEs for paramedics and for any public safety professionals with a behavioral health degree, such as social work or counseling credentials. All participants filling out the survey will be automatically entered for a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Garland Gerber on predatory financial practices in substance use treatment industry. Following that, we'll hear a case presented by Elsa Guardo. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage each of you to share that during our discussion so that we can learn from each other in this space. And with that, we will start with some introductions. Jeremiah.
Hi, everybody. Happy Thursday. I'm Jeremiah Golka. I'm the Executive Director of the SHIELD Training Initiative. We do trainings on the connections of occupational health and safety of police, first responders, and criminal justice professionals kind of across that spectrum in how they interact with and respond to the overdose crisis and rising stimulant crisis, and how to boost their knowledge, their safety, and effectiveness. So always glad to come spend an hour with y'all.
Thank you so much. Cynthia.
Good morning. My name is Cynthia Mendiola. I am a retired federal probation officer. I'm also a trainer and coach in core correctional interventions for probation officers, parole officers, people in the criminal justice field. And I'm happy to be here.
Thank you so much for joining us today. Brandon.
Hi, my name is Brandon Del Pozo. I'm an assistant professor of medicine and public health at Brown. I come to that from 23 years in policing, 19 in the New York City Police Department, 4 years as the chief of police of Burlington, Vermont. Been to Texas several times with your team, so I'm delighted to be here virtually every month. And it's great to see Dr. Gerber presenting today because she was hot on my tail getting her doctorate. So it's always good to see her presenting research.
That's wonderful. With that, we'll move to Dr. Gerber.
Hello, everyone. My name is Garland, also Dr. Gerber. newly minted Dr. Gerber. I am a recent PhD graduate. I come from a clinical background. I have over 15 years working in substance use and mental health treatment. I also am a person with lived experience, formerly justice involved. And so I bring lots of different types of perspectives into the work, and I'm looking forward very much to speaking about something that I care very deeply about. So thank you for having me.
Thank you so much for joining us today. Elsa Guardo.
Hi, my name is Elsa Guajardo. I work with Bexar County Felony Drug Court here in San Antonio, Texas. I am a licensed professional counselor. I've been working in the field probably about going on 20 years now. I've been working with drug court for about I would say about 16 years now. So I am really happy to be here and be a part of this. So thank you, everyone. Appreciate it.
Thank you so much. And with that, we will move on to our didactics. Dr. Gerber, you can take it away whenever you're ready. Are you muted?
I'm going to turn off my screen so I can concentrate on my presentation. Okay. So again, thank you for having me. I will be speaking today on predatory financial practices in the substance use treatment industry. I would really love to save a little bit of time in my presentation to have some discussion around this, because I think there's a lot of discussion lacking in terms of what people know, what's actually happening, how this has evolved, and what it might look like within a public safety occupational setting. Just to give you a little bit of background aside from my intro, I worked my way up in the substance use treatment field. I started, as many do, as a patient. I was in and out of treatment many times, also as many people have experienced. But eventually, when I found a pathway of recovery that worked for me, I became a tech in that industry, which is an individual who does a lot of the dirty work, so to speak, and are incredibly underpaid. These are things like collecting UAs and taking clients out to smoke and running groups when someone doesn't show up or they need someone, right? Like techs are sort of useful for a lot of different things within a treatment facility. Then I eventually became a sober living house manager and was able to see the ins and outs of what's here on the West Coast we call sober living. On the East Coast, oftentimes people call this a halfway house. And then I got up enough courage to attempt a certification at drug and alcohol counseling. This really pulled me out of the darkness of some of the substance use related behavior that I had engaged in and into the light of higher education, and also self-belief that I could actually succeed in academics and also finish what I start, which is also very important in recovery. And then eventually I went back for my master's degree. I became a psychotherapist specializing in addictive disorders and psychological trauma. And then 4.5 years ago, I took the leap and I went back to school to get my PhD and successfully defended my dissertation in 2023. So I share all of this with you so that you know that I have seen the many phases and evolution of treatment, and unfortunately, the good, the bad, and the ugly. So I will share with you what I have seen and what we know. Okay, so disclosures, I have no financial relationships to report, and the views and opinions expressed by myself are the opinions and views of myself and the research and current circumstances within treatment. Here are the learning objectives. So I'd really love for everyone to understand the concept and the scope of body brokering, also called patient brokering, and the associated predatory practices within the context of SUD treatment. Identify the factors that are contributing to these unethical, illegal practices, recognize the common fraudulent practices, and then perhaps we can have a discussion if we have time about the ways in which these practices, the ways in which you might be able to recognize these practices within the work that you do. And then again, discuss issues and implications. Okay. So what are predatory financial practices in SUD treatment? So we know that there are predatory financial practices in other industries, and substance use disorder treatment has its own. It's no different. So before the early 2000s, treatment was mostly either private pay, nonprofit, and or government funded. When I was introduced to recovery in the early 2000s, I entered my first addiction treatment. Rehab was pretty much the last house on the block, and it certainly felt more finite. So basically what that means is that once you were on your way to rehab or treatment, it was the last straw, was the final step in what you needed to do in order to explore a life of recovery. It is not that way as much anymore, and we'll get into the reasons why. It has now just sort of become part of the addiction cycle. Addiction treatment has emerged as a growing industry for organizations, particularly those who are searching for a profit. The percentage of treatment centers operated by government or nonprofit treatment centers, so those that are not receiving as much of a private profit, declined steadily between 2004 and 2006, and for-profit centers increased by 21%. And so what many people may call this, or what it has been called, is a gold rush for those who are seeking profit. And this is caused by a combination of a few different things. And you see here I have listed policy and law changes. So that looks like insurance coverage and payouts, mounting substance use disorder crisis, so the demand for treatment, and then obviously the family and friends' desperation for help, and then also the stigma of addiction. So I'll get into, I'll go further into these various circumstances. So first we have the policy changes, the legislation changes. So in 2008, the Mental Health Parity and Addiction Equity Act was signed into law and went into effect in 2010. And so this is basically federal legislation that mandates that insurance companies cover mental health and substance use disorder related treatments just as they would surgical or hospital stays for other diagnoses. The goal was to eliminate and reduce the disparities within insurance coverage. And so the increased emphasis on the substance use treatment inadvertently created an environment where fraudulent treatment centers saw an opportunity. Here we have an opportunity for financial gain and exploiting individuals who are desperately seeking help and their families who are desperately seeking help. Alongside this act, we have the Affordable Care Act, which was also signed into law in 2010. And this really aimed at expanding access. So not just the coverage that you would get just as if you were going in for a surgical procedure or other medical procedure, but this this aimed at expanding access to affordable healthcare for everyone. And again, even if it had had positive intentions in improving access to care, it also inadvertently created certain conditions that may have contributed to these unethical practices that I've been talking about. There's also the expansion of Medicaid. So the Affordable Care Act expanded into Medicaid eligibility. And the reason why this is important is because this opened up treatment possibilities for more low-income individuals. So you can imagine that when you have a combination of substance use disorder, desperation, availability for treatment, and individuals who are lower income, this makes certain populations incredibly vulnerable to exploitation and unethical practices. And the other point here I have is that the Affordable Care Act created essential health benefits, including mental health and substance use disorder. So this created a higher demand for addiction treatment, leading to an overwhelming increase in pop-up facilities is what we call them. So these could be either inpatient or outpatient facilities that sort of just pop up on the corner and start recruiting clients for treatment. Okay. So I could probably talk all day about what I have seen and what is happening in substance use treatment. Some of these things may be appalling. Some of these things you might have seen or discussed throughout your work. But I'll start with the body brokering, or AKA patient brokering. So this has changed shape, as many unethical practices do throughout the years. So how this happens is that substance use treatment facilities will hire someone who they will call specializing in marketing or reference. The issue with this is that people have been getting paid to recruit patients, to find patients. I've seen and heard from clients that I've worked with that there are oftentimes reference or marketing directors who will go out to places like Skid Row here in Los Angeles and other areas, really looking for people who are willing to go to treatment. And they will say, you know, I can offer you X amount of money if you're willing to go. Oftentimes what happens is that the client has to agree to stay for a certain amount of time until insurance pays out. Usually that's around 21 to 28 days. And then they are free to leave if they wish. This has evolved into reference paying individuals to go to treatment. And if they stay the 21 to 28 days or longer, they will get a cut of the amount. And now referents are paying individuals to go to motels, relapse. They will also even offer them substances, and that way they can restart their stay in another treatment facility. So it's a way to utilize someone to continue making money. Trafficking, you know, is a term for it. So there's also licensing and privacy policy violations. So many treatment facilities, oftentimes they try to fly under the radar or go unrecognizable, operating without certain certifications or licenses. They are oftentimes, if you can imagine, if you're operating under a certain, if you're operating without a certain certification or license, you're probably also not following patient confidentiality laws and other things. So this may look like, I give an example here about an individual who was married to a Kardashian. I won't say the name, but went into treatment, and a few days later, this individual's intake photo was all over the internet about entering into rehab, which seems to be a topic of popular conversation in the media. And so you can imagine where this intake photo may have come from. The reason why I emphasize that techs do not get paid a lot but do a lot of dirty work is that perhaps individuals who don't feel like they are being financially properly paid for the work that they do may perhaps anonymously sell things like intake photos to make some money from somewhere like TMZ. And we also have patient exploitation and trafficking. I mentioned, getting paid to relapse so that you can go to another treatment and start all over again and bill your insurance again. So this looks like excessive treatment. Also, the other point here is that there's oftentimes a time and offering pressure. So much like other financial predatory practices in other other professions, you'll hear things like you only have a day to say yes or no if you want to go. If you do want to go, I can offer you this, this, and this. But if you don't do it today, the deal is off the table. And then obviously trafficking people across the country and other locations in order to find a treatment facility that will take them. Also false advertising and marketing. So, you can pay for your facility to be bumped up when someone is Googling for a treatment or addiction treatment for their loved one or themselves. This oftentimes will prompt you to enter in your personal information, and then you will be getting phone calls from someone asking, or emails or chats asking if you are ready for to start your new life and go to treatment. Also, lots of false advertising around 24-hour nursing care. Come, restart your life in this gigantic home here in Malibu. We offer massages and yoga and lots of different types of treatment availabilities. And then when people get there, it's just a small house, not really much going on. And oftentimes there's no massages, there's no yoga, there's back to back to back groups, because that's how they bill. That's how they get paid, right? You start a group at 7 a.m. Sometimes you're in group on the weekends. I have many years ago worked for a treatment facility when this was really happening, that decided to expand groups Saturday and Sunday so that they could bill for therapy groups. There's also insurance fraud. So oftentimes people will overbill for certain services or bill for services that never happened, whether that's individual therapy, family therapy, a group where someone was not there, but they said they were there. Exaggerating services is another piece. I have had plenty of clients who have told me that they were prescribed medication that they never took, that the treatment facility said, oh, this is just PRN if you need it, but they prescribed it so that they could also bill for that. So that would be, false claims. And then there's something called Vivitrol bans. I have had many clients who have shown me scars all over their body, who got paid to go to a Vivitrol van, get an implant, and then they will pull it out themselves. They get an implant because they get a kickback or a certain amount of money for what they're going to bill insurance. The clients will pull it out themselves, and they'll find another Vivitrol van and get another implant. And this just happens over and over and over again. Some of the other predatory practices that are more well known and sometimes debatable would be, offering someone treatment and then saying, we will pay for your flight to sunny Florida, to this treatment facility. And most of the time, this money is coming from either what they will be receiving from this individual's insurance plan or money that they've made from other people's insurance. Paying for housing, which is, I say debatable because some people say, well, listen, whatever gets someone to treatment, maybe they'll hear something they need to hear and start their recovery pathway. And that is true, but it also extremely unethical in the way that it's been done. So paying for housing, that means paying for sober livings with the insurance money that they're getting from this individual's insurance. So this might look like someone going into residential, and then their insurance no longer will pay for that level of care. So they step down and go into intensive outpatient or outpatient treatment. And part of that money that was made will be paid to the sober living if they have now stepped down the level of care and need housing to continue their treatment. Oftentimes, and it kills me when I hear this, is send me a picture of the front and back of your insurance card. I will call your insurance to make sure that it's cleared for you to attend, and then we'll get you into treatment right away. This is so many times cherry picking insurance plans. So they will want to see what type of insurance you have and how much your insurance will pay for treatment. Sometimes insurance pays 70%, sometimes insurance pays 90% of the treatment. And so really what they're doing, what a lot of these individuals are doing, is trying to figure out whether or not you have a gold insurance plan. Other times, if you do not have a good insurance plan or you have no insurance, but you're willing to go to treatment, these reference marketing professionals or the treatment center itself will buy an individual an insurance plan, choose a fake address, an empty lot or something like that as their home address. And then once they have the insurance plan, they will send them off to treatment. As I mentioned, these referrents often pay people to relapse so that they can go ahead and have another stay in treatment. And then what's happening now, and it's amazing how this evolves, individuals who own various treatment facilities will purchase a giant Amazon warehouse, employ their clients who will become Amazon employees. And the reason why they're doing that is because they have found that Amazon pays out almost 90% of substance use and mental health treatment. Another thing that happens is that when you commit to treatment, someone will say, okay, I need to take your phone. You cannot make any phone calls to family or friends because that might trigger you to not want to go into treatment. And this is very important for your wellness, blah, 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 blah. Basically, to protect one from oneself is how they get away with this, or this is how they're justifying it. And then obviously quality care issues like denying an individual a certain type of treatment like Suboxone, if you will, in treatment, either because they do not provide it or they do not believe in it, which is, as we know, a violation of the ADA, American Disabilities Act. Okay, so statistics. These, I'm not sure how well you can see this, but these are stats from the CDC. This demonstrates the mounting substance use disorder crisis. People are dying, and it has not gotten any better. As you can see, as the years have gone by, 2002 all the way to 2022, it has just gone up. And I chose here the 3 different types of substances that we generally see in treatment. Oftentimes we talk just about the opioid crisis, but I like to not just be specific to that because people are dying with all types of substances and it's just getting worse. You can see here on the left, we have alcohol-induced deaths just rising. We have drug overdose deaths, predominantly opioids, also rising. And then we have drug overdoses involving stimulants, also rising. And I want to shine a light on this because there are a lot of ways in which we are not doing enough or not doing well in terms of addressing substance use disorder. And I think many people are naive to sending their friends, their loved ones, or maybe their clients or defendants off to treatment, not realizing that treatment itself can be incredibly harmful. And so lastly, I have here the stigma of addiction. Substance use disorder is absolutely among one of the most stigmatized and poorly treated health conditions, despite the statistics that we've just seen. Part of the stigma of addiction. So I just want to state that struggling with an addiction is one of the loneliest, darkest experiences, and partially because of the stigma that's associated. We're behind in research, we're behind in treatment, we're behind in conversation, and we're behind in regulation. The addiction treatment industry has been called very often the Wild West. It historically lacks robust regulation. And when I say this from everything from the top down. From certifying bodies, licensing bodies, I have seen and been a part of, unfortunately, treatment facilities who will pay off someone from a licensing body or a certifying body to AKA walk through their treatment center and sign off stating that they are up to par in terms of regulation. So we have from the top in terms of certifying and licensing, all the way down to the requirements for those who work in treatment and who are offering services in treatment. My CADC certification education was valuable, but there were a lot of missing pieces and parts within that education. And those are the people who are engaging with patients quite often. And so, I really want to shine a light on the fact that we need to be doing more and having more discussion around how we are regulating substance use treatment. The vulnerability of individuals seeking treatment. This touches on the individuals and the family and loved ones' desperation. As a clinician, I'm often and have been for years working with families and loved ones of someone who's struggling with addiction. And I can tell you that families often feel a gamut of emotions, but very frequently they're in desperation. They feel ashamed, guilty, terrified, enraged, lost, exhausted. So you can imagine how vulnerable this makes individuals to believing anything for a glimpse of hope and peace. Not sure how I'm doing on time. Okay. I need to wrap it up. So I just have this slide here to show you that some are being investigated, but it is not enough. Oftentimes DAs or federal officials will say, we don't have the time or the availability to make sure that this is being investigated. And so what does this look like? So within a public safety context, this might look like entering into a motel and seeing ODs. This is usually an individual who just got out of treatment because they have been paid to relapse and go back. Someone being transported, pop-up treatment facilities, and then understaffed and overfilled centers and homes. So I'd love to discuss this more with you. I don't think we have time. And then I have a trailer here for a movie called Body Brokers. Please, when you have time, watch this. It is
You've been using 10 years.
An incredibly accurate portrayal of what is happening in treatment. And here are my references, and thank you very much for taking the time to listen to a very, very, very important topic.
Thank you so much, Garland. This was an amazing presentation. I will open up the floor for any questions or comments our learning community may have here. Yes. Dr. Clancy.
Hey there. So thank you very much for this presentation. I think that sometimes we need the reminder of what patients go through, right? Because we live in our own little silos and only see what we're doing. This question might be a little bit outside your scope, but this group in particular is about public health and safety. And it seems in recent years, facilities for mental health and substance use disorder are now advertising that they treat veterans and they treat first responders. And, are there any regulations towards being able to advertise that? Are there any studies going on how to reach this group specifically? Because they are a vulnerable population, and they're
Absolutely.
equally at risk from being taken advantage of, like you described here.
Yes. Yeah. Great question. As far as I know, there have been some attempts at changing policy and regulation around marketing, particularly for mental health and substance use disorder. As far as I know, it's still the false marketing is still going on. I don't know where that is in terms of legislation, but I think it's something that we need to be to identify a treatment facility that may be unethical. And so I don't know much about the research that's going on, particularly with that population itself, but I can absolutely say with confidence that it is another very vulnerable population that falls prey very often.
I agree. Well, thank you very much.
Yeah, thank you so much. In the interest of time, I would keep the questions coming in the chat, but we will move on to the next part of our session. Garland, thank you again for this wonderful presentation. This is a very important topic, and we are so glad that you were here to share this with us. As I mentioned, please keep the questions coming. Let's keep the conversation continue in the chat. In the meanwhile, Taylor, if you could please bring up the announcements from Beeville, Texas. Thank you. The Center for Substance Use Training and Telementoring CSTAT offers technical assistance for various substance use disorder needs and topics via a team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. And we can drop the link in the chat. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is facing and receive expert feedback from our hub members. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. You can email us at cstat@youthiska.edu. Next slide. Join us for our next webinar. It's called Communicating During a Public Health Emergency, Strategies for Effective Culturally Responsive Interventions. This will be on Tuesday, June 18th at 12 p.m. Central. We will drop the link for registration in the chat. Next slide. And please join us for our next ECHO. That will be on Thursday, July 11th. And we will be discussing best practices for compassionate overdose prevention in the age of an evolving drug supply. And with that, we will now move on to our case. Taylor, if you could please share the case form, and Elsa, you can take it away when you're ready.
Sure. Hi. My case, can y'all hear me okay?
Yes.
My case involves a 37-year-old female who was referred to us by one of our district courts. When she came in for her screening, her scores did not meet criteria for the program. However, part of the screening process is to have them submit a UA. When she submitted, she was positive for multiple substances. So in case of, instead of rejecting her case, we had her come to our drug court review. We wanted to rescreen her talk to her a little bit, get her to hopefully answer the screening tools more honestly, so we can hopefully be able to justify her admittance into the program. However, when she came in, it was she was late for once. She was unwilling to give us a drug test. She was stalling techniques that they do. She spoke loud, pressure speech. She was crying. She was a bit manic. She was, of course, identifying herself as the victim, that we're doing this, we're saying that. She would not let us speak. We found her with some unprescribed Suboxone on herself. She flushed down the toilet because she did agree to give a UA. Went in there, it fell out. We also found some fake urine on her. And so we had to regroup the team. We went ahead and had her sit in the jury box to calm down, and to also maybe observe what goes on in court proceedings. So that seemed to work after a while. We spoke with her again. She was willing to speak a little bit more. We had to wait for her to get a little bit more, I guess, coherent, if you will, to actually let us speak to her, let her process what we were telling her. And ultimately she did calm down, and Judge actually went in there with us, and he spoke to her as well, and that seemed to make the difference. So when we got her in a better place, I went ahead and went over the screening tool with her, and she was honest, and it was a completely different story by then. And we were able to go ahead and have her drug tested. She was positive, and we were able to, talk to her about it. And we had her mom come over kind of as a safety guard, if you will, because she was talking about her mother and what she does. And that made her trust us a little bit more. So we were able to sign her on and get her into services. Any questions so far?
Miss Guajardo, I have a question.
Sure.
What encompasses your drug court? You said that you got the team back together, kind of a regroup. What encompasses your team?
Okay. Well, in this case, it was myself, a case manager, one of our counselors, our therapist, and it was our court manager, who's very well versed in what we do. She has a long history with working with people and with a judge. So
Okay, and the court manager, is that a probation officer?
No, she is our court manager. She has our background in probation, but she also has a lot of experience working with our individuals.
Okay, and so does the probation officer have an active role in this team?
Yes, they do.
And where are they at in this situation? I'm curious.
Well, they also participate, and they also give a reassurance if they have questions, and they also, talk about what's going on, their conditions and things like that. But they're also trained to speak with these people in a way that's not so punitive, but more therapeutic, if you will.
Okay.
So that's where they come in.
Thank you.
You're welcome. Okay. So, of course, her drugs of choice are heroin, methamphetamine. She also does them in the form of a speedball, IV and nasal. She also was using Suboxone at the time. She does have a long history of mental health issues, including PTSD from past abuse and significant medical issues. She has lost her children to CPS, and she does, her mom actually has custody of them. She lacked insight to any kind of substance abuse disorders and her mental health disorder, and she didn't have any knowledge about resources available to her. So that would include some of the context that she's coming from. Barriers that we did encounter was, of course, she had zero trust in us and what we do. Her attitude was very oppositional. She didn't know anything about the program. And and the number one thing is worried about going back to jail. What went well was, of course, after giving her some time to observe, to look at what we do, she calmed down, and and then after she spoke to judge, she definitely began to start accepting what we were telling her. I think what I would have done personally, in this scenario was probably bring her in, or most likely have her come in outside of a court review. I think that just because there's a lot of distraction going on, people, court review can get very busy. It could be, you never know what's going to happen with the case, things like that. So we had to balance it very, very carefully, if you will. Success for this case, of course, would be medication stabilization, both for psych and MAT. Probation does have an MAT program now. We would definitely want her to begin substance treatment right away. Teach her about the staying away from people, places, things, situations, using her coping skills that she could learn in treatment, learn about sobriety, work 12 steps with a sponsor, and engaging MRT for trauma, maybe a recovery coach, things of that nature. Referrals that we did make were, we did refer to we started an IOP because judge wanted to gain some trust to see if she could follow through. Of course, we had also signed conditions for residential treatment in abeyance. She was referred to our clinic, our site clinic for services through what we call the Center for Healthcare Services Jail Diversion Clinic. And of course, she was assigned to a case manager to supervise case and referrals. So all that, of course, every one of us, we had to follow through what we do, which we did. And this is where we are right now.
Thank you so much, Elsa, for sharing this case and bringing this to us. I will now open up the floor for any questions or comments from our learning community.
I have to jump off in a moment, so I sent that to the team, but I did want to get one ball rolling on, and we brought it up in the huddle, but I feel strongly about it. That's the use of non-prescribed buprenorphine. In my experience, I take that as a person's effort to self-manage addiction. There's also research that suggests it's an indication that the person wants to treat their addiction, but doesn't either feel like they can trust the healthcare system, trust their providers, doesn't have adequate access. I was wondering if you thought about how the, possession and use of the non-prescribed buprenorphine fit into the analysis of the client.
Well, we can look at it that way for sure. We also have to make sure that they're not dealing it, because people do buy it off the street. So that also comes in play. And looking at this, we also would rather have it prescribed. If they need it, we would rather it go through a doctor and be prescribed and take it safely. That's how we look at it.
Oh yeah, no, I agree, and I think that's right. You get better clinical results often when a doctor prescribes it. But one of the ways, I'm not an MD, right? But I am studying this with some NIH funding, and people who use drugs frame non-prescribed buprenorphine use as a positive thing. Like they say, I wish that my providers and my probation and parole and everybody would say, wow, this person wants a medication for opioid use disorder, and they're struggling to get it in their own way with their sort of, I'm going to say offbeat, I don't mean to stigmatize, but they have a different worldview as a person who uses drugs. They don't necessarily see doctors the same way we do, but hey, I want the MOUD. So maybe reframe it as like a positive indicator. Notwithstanding, dealing it on the street.
Right. Okay. Again, it's like a careful balance that we have to do. And we do offer the MAT, and we got her in there pretty quickly, as a matter of fact, to talk to somebody and hopefully get on what she needs to help her in her addiction. And of course, that also goes with her trusting us, because like you said, their outlook is very different. They don't trust anybody. So, and accepting them for where they're coming from, and then being open to, sure, I would never deny anybody a chance to get on medicated assisted treatment through methadone or Suboxone or naltrexone, those kind of things. So it's just one of those things that we definitely had to look at. We definitely had to make sure it's not something that they're dealing. But that always comes out later. We won't tell them, no, you're dealing it, you can't have this or anything like that. We look at it, this is something that could help you, let's do it. So yeah, we come a long way with that, with those kind of situations for sure.
Thank you.
One of the things that I noticed is that that I was glad to hear, because I didn't see it in here, but I think you're coming from the perspective of the treatment agency, the counselor. But that I like the fact that there's a team, the team that encompasses it also includes the probation officer. And you mentioned a little bit about some of those officers that work with you are trained to talk to them in a way that is non-threatening, so that the individuals can feel comfortable in a safe environment to be truthful and to divulge what's really happening with them, which is a positive. But I think that what's important is that I think that the probation officer needs to take a more active role to help the treatment providers to kind of be more proactive and kind of look at, okay, what are some things that we can do to help the counselor, so that the counselor is not in a position of being like crisis intervention, like you're trying to piece everything together, when maybe if the officer took a more of a lead, the officer might be able to help minimize some of that crisis. And I'm, I don't know, am I on the right track with you?
No, you're absolutely. We are very fortunate to have the probation officers that we do have, because they are willing to jump in and offer any kind of reassurances to them. Like I said, we actually have a MAT team through probation, so they're the ones that will refer them to be evaluated for that service. Probation officers are willing to jump in and talk to them in a way that makes them understand, yes, you have this part of it, but then there's also help here. And when it comes to crisis intervention, the whole team is a part of that: case managers, counselors, probation. We're sometimes I'll be in here working on something, and my manager will come in and say, hey, Elsa, can you come talk to this person? This is going on. And I'm happy to do it, when we also do that with probation officers, our counselors as well. So we definitely don't want them to feel overwhelmed. We don't want them to feel that we're punishing them or blaming them, or you're going against this and this. Or we have to be very patient against it. It's also a fine balance that we have to practice, if you will.
Thank you.
But
And
thank you.
hi, Miss Cynthia and Miss Elsa. This is Melissa Lucio with Bexar County. How are y'all?
Hi, we're good. Thank you.
Good. And yes, and so I wanted to echo what Elsa's describing here. The FTC program, the felony drug program, has great collaboration with the probation department, with Bexar County Behavioral Health. Though there's cases that they send to us for further screening regarding SUD diagnosis, so that we could get them into residential programming, be it at Lifetime Recovery, Alpha Home, or Pay It Forward here in the community. And so, but Cynthia, with your point, I think maybe it's a great idea to, let's say, recognize the probation officers that deal directly with Judge Glenn and Ms. Guajardo here, and perhaps provide a training or an information session, if you will, there at the FTC court, so that we can work collectively together for the same objective that we're trying to implement. So if y'all are interested in that, Elsa and Cynthia, I know that you have a database, Cynthia, of all the probation officers that work the SUD. We can definitely set that up.
Yeah, I think, and Judge Glenn, I'm very familiar with Judge Glenn. He's very good at taking in new information, but I sometimes think that the probation officers tend to sit back a little bit and not be as proactive, so that they could, so the goal is to not have individuals at a crisis point, right?
Right.
To be able to be proactive, to have those good assessments with the counselor, in collaboration so that they can pick up before all of this happens. And
Absolutely.
I think, then supervision, not only supervision, but their recovery would be more successful and more effective, I think.
It's amazing when actual those probation officers that you're speaking about, when they do practice what you're talking about, the outcome is a lot better. I mean, they're thanking them at graduation in their statements. They're just they can't believe how much help they got from the whole team, not just from counselor, case management, but probation. We've come a long way with them, because you're right, a long time they were just kind of sitting back, and we've had to bring them forward, because especially courts, especially felony drug courts, where justice meets treatment. So everybody has a say so. Everybody needs to be trained. Everybody, there's a long time ago, but when I first started, we had probation officers that were still stuck in that punitive downgrading.
Yeah.
You know, it was really hard. And they would come to us and we would have to do a stabilization. So Judge Glenn got on top of that. So he makes sure they do their training. He makes sure that we're corroborating with their manager, with the probation officer. And then we show them when they first come to us, if they're a brand new officer, never been in a specialty court, we have to show them, and our other probation officers, our seasoned drug court probation officers, will tell them how we run things and how to approach. And it's different, but eventually they get there.
Yeah, I agree. And I know that Cynthia and I have been working this for a long time, and I do believe in immersion training. So what I'll do, Cynthia, is I'll get with Ms. Guajardo and our team and identify some probation officers, and maybe we could have an immersion training type over at FTC or at the reentry center. That way we can incorporate and make sure that everybody knows that this is a treatment reform, therapeutic justice type, and if everybody's on the same page, we will have more success in these folks that we treat.
I think that's an awesome idea. It's also it will practices in the field, you know, together with the treatment providers. But and one of the things that we wanted to make clear on the evidence-based practice, so everybody is on the same page, is that you said they were working on the 12-step with treatment providers. Most treatment providers usually work on making sure that a treatment plan includes supportive community resources. Is that correct, Elsa? Is that one of the reasons? Okay, is that one of the reasons why you use 12 steps and a sponsor with that client and other types of programs?
Yeah, for this certain case, I mean, it would look like a success. It would be hopefully within treatment to educate her about these self-help support groups, if you will, in recovery. And for her, my hope for her would be maybe hopefully build that community sober foundation through a 12-step program, through a sponsor, because I believe that works.
Okay, so you're using the 12-step approach as a self-help group, some community support, some recovery support. So if she, let's say, is off of the supervision or the courts, she has somewhere in the community to follow through. Okay.
Yes.
Because there isn't a lot of empirical data backing up 12-step programs, but there is a lot of information saying that support groups and community support groups are very beneficial for individuals in the community.
People respond differently to different models, if you will. Right. I mean, some people are very connected with the 12 steps, whether it be NA, AA, you know, and even with their families or Al-Anon, R-Anon meetings, things like that. Some people are better just with, they do better with a recovery coach, getting involved that way. Some people.
I think there's rational groups. What is it? Rational recovery groups, I think, that deal with CBT kind of concepts.
Oh, wow.
Out in the
I'd like to more about those. Yes.
Yeah.
Some people connect better with their church. Some people connect better with refuge recovery, celebrate recovery. I mean, there's so many things out there and they connect. And we do find better success when people have that, because we tell them we're just the beginning. This is something that you're going to have to do for the rest of your life, and we want you to have that support. So I use 12 steps in here because I thought that would, you know, if she got to know them a little bit, that, you know, would open her eyes and help her. But we are supposed to call it a support recovery
To connect
connections,
them to
if
the
you will.
community,
Mhm.
to have other individuals that are going through recovery to
Oh,
work
yes.
together. Okay,
Yes.
awesome.
Thank you. Before we close, this has been a great discussion so far. I did see Jody, your hand was raised for a while. Did you have a question or a comment?
Well, I just think that when we get empathetic about the individuals, which I saw through that case study, and I noticed that they kind of educated her in a lot of different. When she came in there, she was scared to death, right? She's fearful, and so that's how she's acting out. But I saw as the case went on that there different individuals approached her empathetically and educated her how the court happens, how the process goes, and how they can help her. And as she was being educated, I could see her level of anxiety going down and her being more receptive to recovery and plan to help her in her plight. So I think that, you know, everybody's plan is different and everybody's direction is individualized. And so I think that's what I heard in the discussion, that no matter what the plan involves, as long as the person's receptive to it, and they're the ones that make the plan. And so I saw that going on, and I think that's really cool that she was being educated with her people around her being empathetic to her needs.
Thank you.
Thank you.
Cynthia, if you could please help summarize the case for us today.
Oh, yes. So I want to just add a few things about the lecture, which was a great lecture. It kind of opened up my eyes to it as to some of the things that are going on out there. And, you know, there were some things that I saw a couple of things that I was not happy with. And sometimes we do ethics, you know, lectures and training and go through the fact that, you know, if some of the things that are going on in your organization seem to be unethical and against your code of ethics, you sometimes have to leave that, you know. And so we sometimes have to make those decisions. And I think this training just opened my eyes as to how great that exploitation and that those violations are out there because of all the monies that are coming in for treatment providers. But it also in the fact of the case plan and the case form, you know, thank you very much, Ms. Guajardo. It was a great scenario, and it kind of opened my eyes on, you know, how can we better help that team of yours and help with officers training on, you know, how can we get them more as a lead to help you so that it doesn't become a crisis and it's more of working together towards a positive, you know, accomplishment in getting the right treatment, you know, and then of course there's a process, you know, which comes first, the chicken or the egg? Is it, you know, do you deal with the mental health first? Do you deal with the substance use disorder first? How do you work that out? You know, and so these were all good things that came up in the case plan that I think have potential for us to try and see how we can get better education out there and more knowledge about working in a collaborative way that is more effective and it's more supportive of a person accomplishing, you know, supervision and recovery in a successful way and more effective way. And then we also learned that, you know, 12-step programs and other similar programs like that are beneficial for individuals in recovery as they transition as a continuum of care, as they transition into the community and they become and see themselves alone, you know, and then they've been connected with those supportive groups, self-help groups. Thank you.
Thank you so much, Cynthia, for the summary. And thank you again, Elsa, for presenting this case. And thank you, Garland, for that wonderful presentation earlier this hour. And thank you all again for joining today's session. As a reminder, to earn continuing education credits, please complete the post-session survey using the link in the chat. If you would like to present a case, please email the BVAL Texas team at cstat.utisca.edu. We look forward to seeing you in the next session on Thursday, July 11th at 11 a.m. Central. Thank you. Have a wonderful rest of your day. Bye-bye.